In this, first of all, we talk about dysphonia. What is dysphonia? In this, there is reduce in the sound volume. It is just like patient has whispering or patient voice is hoarse voice. Okay. And then we have the term called dysphonia. Most common cause of dysphonia is laryngitis. Also called sore throat. It's quite possible that you may have experienced laryngitis, then you find your sound volume is too slow, too low volume, or even the quality of sound is not clear, right? Otherwise, this can also occur in tense cranial nerve lesion because that supplies the vocal cord, and of course dysphonia also occur in Parkinsonism. Okay. The second term what we use is dysarthria. In this, there is poor articulation or there is slurring of the speech. Articulation is not proper. And slurred speech is there. And the usual causes are cerebellar disease, or it may also occur in brainstem lesion, and it can also occur in myasthenia gravis. Okay. And the third problem what we have is speech is dysphagia, also known as aphasia. Here the problem is of language content. Okay. And this occurs when the lesion is in the dominant cortex. This we'll talk in detail. In fact, in the exam, typically this thing what is they usually ask, right? So we'll talk about aphasia or dysphagia in detail. In fact, dysphonia and dysarthria are usually discussed by ENT wala, but the medicine people, they talk mainly about dysphagia. So before I discuss dysphagia in great detail, first of all, we learn the anatomy and physiology of the speech mechanism. So here's the cerebral cortex, central sulcus, and this is the motor cortex. Okay. And this is the parietal lobe. So this is the occipital lobe. This is temporal lobe, parietal lobe, and of course this whole is the frontal lobe. In fact, this red color is the central sulcus. The part which lies in front of central sulcus is the frontal lobe. And this is the motor cortex. In the motor cortex, this is the leg area and this is the head area. Right? So, In the temporal lobe, we have a auditory center. And in the posterior part of the superior temporal gyrus, we have a Wernicke's area. It lies in the superior temporal gyrus in the posterior part of temporal lobe. And in the inferior frontal gyrus, we have a Broca's area. It lies in the inferior frontal gyrus. This is a motor speech area. This is a sensory speech area. And these two are united via arcuate fasciculus. Okay, this was the anatomy. So now, unless you know the physiology, you will never understand the speech. So let's talk about physiology. Suppose we ask somebody, what is your name? Okay, our words go to his ears, both the ears. From both the ears, they come to both the temporal lobe, both sides. Here we have auditory center, auditory center. Here the voice goes. Some sound has come in both the temporal lobe. From there, message come to dominant temporal lobe. That is Wernicke area. Point to be noted, Wernicke area is present only in dominant temporal lobe. Here the speech is understood. Understanding occurs. Understanding of speech, so-called what comprehension of the speech, what the usual textbook writes. There we understood what the question is. Question was, what is your name? So this Wernicke area understood the question to be sensory speech area. Now it will send the message to Broca's area, which is a via fascicular arcuate fasciculus. It is a motor speech area. From here, it will give a command to vocal cord lips. Just see how beautifully God has made our body. The Broca's area is quite near to head area. And the message goes to vocal cord and lips, and the answer comes, my name is XYZ. This is the physiology of speech. Just a quick revision. This is the where the speech is understood. Here where the command is given to vocal cord lips. And this is how the speech is completed. Now let's see what happened in the diseases of various parts. Suppose there is one patient who got head injury, and the head injury, he got injury in the Wernicke area. Wernicke area is not working. Now you ask a question to him, what is your name? Your words go to his ears, from they go to auditory area. But now the message come here. But he could not understand the speech. Why? Wernicke area is not working. The question was, what is your name? And because he could not understand. What he will reply? Oh, no, I will not take dinner. You again say, what is your name? No, I have already read the newspaper. You are asking something, he is replying something. So there is irrelevant rapid speech is there. Why? He is not understanding. So in Wernicke defect, there is irrelevant rapid speech. Why rapid speech? Because Broca's is normal. Why irrelevant? Because you are talking something, he is replying something. Okay? So now let's talk about, suppose there is one patient whose Wernicke is all right, but his Broca's is not working. You ask, what is your name? Your words go to his ear, they come to auditory center, and they come to Wernicke area. He understood. Understood what is the question. Question is, what is your name? Now it give a command to Broca's area. But Broca's area is not working. It cannot give a command to vocal cord lips. Okay? So he cannot speak out. So now you ask patient, what is your name? He will stand quiet. Will you go to movie? Will you have dinner? Then you say, Arey, please speak out. But he cannot speak out. You said, will you go to movie? He can do this thing because he has understood what you are asking. Will you take dinner? He says no. He understood. But he cannot speak out because Broca's area cannot give a command to vocal cord and lips area. So friends, in Broca's defect, speech outflow is reduced. Remember, he understands, but he's not able to speak out. Well, we have a term called global aphasia. This when both these are involved. When both Wernicke and Broca's are involved, then we call it global aphasia. That means neither he can understand, neither he can speak out. And this typically occurs in middle cerebral artery lesion. Because middle cerebral artery supplies both these center. Right? Then we have a term called nominal aphasia. In this patient is not able to name. He forgot the name of the object. Like he want to ask a pen from you. He forgot the name pen. He will say, please give me something with which we write with blue, but he forgot the name. Nominal aphasia. And nominal aphasia is classically seen in metabolic encephalopathy. Or is also an early feature of Alzheimer's disease. So to summarize the whole show of aphasia, in Wernicke aphasia, irrelevant rapid speech is there. In Broca's, outflow is reduced. And in global aphasia, both are involved. And nominal aphasia, where he forgot the name. Right? Now, in addition to all this, we have something more to talk to you. We have pure aphasias. Pure aphasias. What do you mean by pure aphasia? There is a defect in a particular part of the speech. Like, patient can read, but cannot write. Patient can write, but cannot read. These are the terms we call pure aphasias are there. Okay? They are also a part of the speech, because speech is a very complex topic, but I still try to summarize in as short as possible. Right? So, Aphasia is the language content. Broca's is unable to speak out. Wernicke able to understand. And nominal aphasia cannot name. Well, I can give you a simplified, in a lighter way I can say. In Broca's aphasia, he wants to say something, but is not able to say. Well, this happened with the boys. Some